Welcome everyone to our second webinar where I get to ask Dr. Avrum Bluming anything I want about menopause and estrogen and all of the above. I want to introduce you to him first and then tell you how we met, and then we'll dive right in. I know that people are going to continue to join. We have a lot of people signing up, but we're going to start on time because there's so much to talk about. Dr. Avrum Bluming received his Bachelor of Arts degree from Columbia College, where he majored in music, and his MD his MD degree from the Columbia College of Physicians and Surgeons, where he was elected to the Academic Honor Society Alpha Omega Alpha. He spent 4 years as a senior investigator for the National Cancer Institute and has taught at medical and academic institutions, including Harvard, Princeton, Johns Hopkins, and Columbia Universities, as well as UCLA and USC. He is currently an emeritus clinical professor of medicine at USC and has been invited to speak at the Royal College of Physicians in London, the Pasteur Institute in Paris, and the International Society of Hematology in Jerusalem. And if I went on to list all of his accolades and accomplishments, we would be here all night. But I did want to mention that he organized the first study of lumpectomy for the treatment of breast cancer in Southern California in 1978. And for over 3 decades, he's been studying and publishing the benefits and risks of hormone replacement therapy administered to women with a previous history of breast cancer. His book, which is how I came to know him, published by Little Brown and written with Dr. Carol Tavris, a social psychologist and author, is entitled Estrogen Matters: Why Taking Hormones in Menopause Can Improve Women's Well-Being and Lengthen Their Lives Without Raising the Risk of Breast Cancer. Since its first printing in September 2018, it has been ranked by sales in the top 0.5% of all books on Amazon. And it is no wonder. Welcome, Dr. Bluming. Thank you for joining us here at Alloy.
Thank you, Anne. It's a pleasure to be here.
I just want to get a quick sales pitch. Oh, someone says they can't hear us. Can everyone hear us? Melissa, can you hear us now? Hope people can hear us. Someone just write a little something in the chat if you can hear me. Okay, phew. Thank you. So I also just want to get a little sales pitch for Alloy. We are a women's health company serving the needs of women with menopause. Our website is myalloy.com, and if you join tonight, you should use the coupon SAVE25 now, and we'll flash that up on the screen at the end. But we are almost exactly a year old and have been helping women with their menopause symptoms now for almost 365 days. It's been phenomenal. But I actually met Dr. Bluming, I think 3 years ago or so, when you spoke about your book on the Upper East Side of Manhattan, and it really changed my life. At that point, we weren't sure what we were going to do with Alloy. We knew we wanted to help women in menopause. And after I heard your talk, I just went back to the office and said, we got to sell estrogen. and thus began the long journey that has, the really wonderful and long, exciting journey that has been building this women's health business. Dr. Bluming and I, when we first spoke about doing this talk a month or 2 ago, I had asked him if he wouldn't mind speaking about the new revised guidelines from the North American Menopause Society, because we at Alloy were very excited about them. I won't go into the long list here, but basically the essential takeaway was that more women than previously thought were eligible to take HRT for menopause, and for a longer amount of time than previously thought. So that's what I was going to press Dr. Bluming on until last week. We received a very big pronouncement from a very prestigious sounding place. The United States Preventive Services Task Force came out with a pronouncement about menopause and HRT. And with that, I'm going to hand it over to Dr. Bluming, who will do a quick presentation, and after which I will ask him some questions. And please be sure to type all of your questions in the chat as we go forward, and we'll make sure and make time for them in the second half of the evening.
Thank you, Anne. A little over 30 years ago, there was an editorial in the New England Journal of Medicine by Lee Goldman and Anna Tosteson. Lee at the time was a cardiologist teaching at Harvard Medical School. He subsequently became the dean of the Columbia University College of Physicians and Surgeons, where he served until this past year. And what they wrote was an editorial entitled "Uncertainty About Postmenopausal Estrogen, Time for Action, Not Debate." That was over 30 years ago. And they wrote that women who were given postmenopausal estrogen had a 40 to 50% reduction in the risk of coronary artery disease compared with women who had not taken hormones. You would think that that would have been elaborated on over the last 30 years, and you would be right. It has been elaborated on, and there are now numerous articles supporting that conclusion. In 1995, Bernadine Healy, who was at the time the first and thus far the only female director of the National Institutes of Health, wrote a book published in 1995 called A New Prescription for Women's Health, Getting the Best Medical Care in a Man's World. And what she wrote in the book is many of the major risks that women face as they age, heart disease, stroke, osteoporosis, and Alzheimer's disease, are or may well be reduced by hormone replacement therapy. That was almost 30 years ago. She said as a result of those data, when she hit menopause, she planned to begin hormone replacement therapy without a blink. A decision not to consider hormone replacement therapy is a health decision too, just as is the decision not to take a flu shot or get a hepatitis vaccination. And she concluded, as I see it, women have a competitive health and survival edge before menopause. I see no reason to relinquish that advantage after menopause, not if I can help it. That was almost 30 years ago. And then in 2002, 20 years ago, the Women's Health Initiative published their first report in the Journal of the American Medical Association. This is an organization of very respected clinicians and epidemiologists who did 2 prospective randomized studies to see whether estrogen alone given to women who don't have a uterus as they reach perimenopause versus estrogen plus progesterone given to women who still have a uterus benefit by getting hormones. It's just that they didn't start those patients at age 50, 51, when most women reach menopause. Their median age of their study population was 63, long after most women go through menopause. And they concluded that they found an increased risk of breast cancer, heart attack, stroke, dementia, and death, and no improvement in the quality of life among women who got hormones compared to women who didn't get hormones. And we can argue about those results, and we will, but that's what their study showed. And as a result of the press release that came before the study was published in the Journal of the American Medical Association, and the huge media coverage of this report, which, by the way, cost $1 billion, they were responsible for hormone prescriptions falling from about 44% of peri and postmenopausal women in the United States to less than 5%. And it stays at that level now. Between 2002 and 2022, over the last 20 years, the Women's Health Initiative has walked back every one of those alarms. If HRT is initiated within 10 years of the last menstrual period, which is when most women seek prescriptions for hormone replacement therapy. And so many of us in this field have been very comfortable working with some of the people in the WHI and supporting the conclusion that benefits far outweigh risks. And in fact, the NAMS guidelines that Anne referred to at the beginning is well aware of those walkbacks. Imagine our surprise when last week in the Journal of the American Medical Association, the United States Preventive Services Task Force, abbreviated USPSTF, came out with a report saying after review of all the data, they concluded with moderate certainty that the use of combined estrogen and progesterone to prevent chronic conditions like heart disease, Alzheimer's disease, osteoporosis showed no net benefit. And when estrogen alone was given to women who no longer have a uterus, there was no net benefit as well. And we were astonished by this report. When you read through the report, you get the sense that they are referring to the 2002 initial report and ignoring all of the walkbacks. So let's look at what we know about what hormones do for the peri and postmenopausal women. First, the symptoms of menopause. Hot flushes are well known as a symptom of menopause. And by the way, I used to say hot flashes. I'm not a woman. It's really a flush, not a flash. A flash, if you think of a flash bulb, comes and goes and it's over. A flush usually starts somewhere deep inside, either your chest or your head. It spreads to your face so you get red. You start perspiring around your hairline. It can last 15 minutes. It can occur up to 8 times or more a day. It's a major symptom. Night sweats, well, we all know about that. Insomnia. Joint pains, not widely publicized. Swelling of the hands and feet. Palpitations. Many cardiologists working in the United States today are not aware that palpitations are a known side effect of hormone deficiency. And that goes with chest pain with exertion, decreased energy reserve, difficulty concentrating. This is one of the major symptoms that isn't widely publicized. Poor recent memory, mood swings, depression, thinning hair, bloating, weight gain around the abdomen, and then what is called the genitourinary syndrome, vaginal dryness, vaginal discharge, bladder and urinary discomfort, frequent urinary tract infections because of the vaginal dryness, loss of sexual desire, and if you force yourself to have sex to please your partner, sexual intercourse is painful. That's terrible. And what we as men used to say, I used to think it, is, well, it'll last 1 or 2 years. You're a woman, deal with it, essentially suck it up. Well, the median duration is 7.5 years. And estrogen will decrease the frequency and severity of these symptoms by 80 to 95%. No other treatment comes close. So when the Women's Health Initiative initially said that hormones had no effect on quality of life, you have to ask yourself, how could they say that? And if you read their article from 2002, you find that what they said is this was a prospective randomized double-blind study. And we knew that symptomatic women would know within a week whether they were getting hormones or a sugar pill. And if they were symptomatic and getting a sugar pill, they would drop out of the study. So we went out of our way to see that those people who joined the study were not symptomatic. And those women who were not symptomatic had no improvement in the symptoms they didn't have when they were given hormones. And then there's heart disease. A woman is 7 times more likely to die of heart disease than to die of breast cancer. And what I usually hear when I say that is, well, old women die of heart disease and young women die of breast cancer, and I'd rather die when I'm old than die when I'm young. And that's not true. In every decade of a woman's life, starting at 40, her risk of dying from heart disease is greater than her risk of dying from breast cancer. And the difference in risk grows with each decade. Even among women with diagnosed breast cancer, the leading cause of death is heart disease not breast cancer. Repeated studies have confirmed what we saw from 30 years ago, published by Lee Goldman and Ann Tosteson, that estrogen decreases the risk of heart disease by 40 to 50% more reliably than statins. And then there's osteoporotic hip fracture. The number of women who die each year following an osteoporotic hip fracture is similar to the number who die from breast cancer. Calcium and vitamin D administered to postmenopausal women not on hormone replacement therapy do not decrease the risk of these fractures. Long-term hormone replacement therapy is more effective than bisphosphonates like Iridia, Zometa, or Prolia in preventing femoral fractures, and postmenopausal estrogen reduces the risk of osteoporotic hip fracture by 30 to 50%. If you're still not impressed with what these hormones can do, don't leave. Brain. If there's one thing women are more afraid of than breast cancer, it's Alzheimer's disease or cognitive decline. In 1900, only 5% of all American women lived beyond their 50th birthday. Today, their life expectancy is close to 80 years. A woman in her 60s is twice as likely to develop Alzheimer's disease as she is to develop breast cancer. While 90% of newly diagnosed patients with breast cancer will be cured, there is no current effective treatment for Alzheimer's disease. The only known effective treatment is estrogen, which, when started within 10 years of the menopause, has been found to reduce the risk of dementia by 24 to 65%, depending upon which study you cite. Now, there is no double-blind, prospective, randomized, controlled study of hormones to prevent cognitive decline, and I can't imagine that there ever will be. But when I hear jellyfish products being used to help cognitive decline, that's all nonsense. Nothing works. The fact that Medicare approved a $250,000 per treatment medicine for Alzheimer's disease, an approval that has since been rescinded because all it did is maybe improved cognitive decline by 1 month, shows you just how desperate the situation really is. And this is staring people in the face. And what about longevity? I mean, if you really feel well and you look good, you'd like to live a long time, even if you don't look good. So if we talk about longevity, over 20 years ago, Nananda Cole, an epidemiologist, then at Tufts, subsequently at Harvard, estimated that nearly all postmenopausal women would benefit from taking hormone replacement therapy, as measured by decreased rates of disease, heart, bone, lung, breast cancer, and improved longevity by up to 3 years. In 2017, Roger Lobo at the Columbia College of Physicians and Surgeons found up to a 40% reduction in overall mortality rates for women on hormone replacement therapy. And even the Women's Health Initiative, in a 20-year follow-up report, found that women receiving postmenopausal estrogen did not have an increased risk of breast cancer. They had a significant 23% less likely risk of developing breast cancer. They had a 40% less likely risk of dying from breast cancer, and they were less likely to die from all causes after a breast cancer diagnosis compared to women taking a placebo. And so the question is, what's keeping people from taking estrogen? And if you ask a woman on the street, the most likely answer you would get is, well, estrogen causes breast cancer. Well, really? First, breast cancer rates rise after menopause as estrogen levels fall. You would expect, you see where the 51-60 age label is, you would expect breast cancer rate to start dropping at that point, since estrogen dramatically falls in a woman not on hormones at that point, and yet the rate of breast cancer continues to rise. In fact, after gender, age is the strongest risk factor for the development of breast cancer. The older a woman gets off medicine, off estrogen, the higher her risk of developing breast cancer. In addition, people have said, doctors have written, that lifetime exposure to estrogen is a risk factor for breast cancer. And in the book that Anne mentioned, we attack that. And that's based on very flimsy data. And in fact, the full-term pregnancy before age 20, which we are not advocating on this program, but clearly that floods the body with estrogen and progesterone, reduces subsequent breast cancer risk by 70%. Inducing an abortion in a newly diagnosed breast cancer patient, you would think if estrogen was responsible for the breast cancer, it would be associated with an improved prognosis. And we used to do that. And it does not improve the prognosis, and it may even worsen the prognosis. Pregnancy, either during or after treatment for breast cancer, again, flooding the body with estrogen and progesterone, has no negative effect on prognosis. And if estrogen doesn't cause cancer, and by the way, if you have estrogen pills and you open up your prescription, you will see that there is a black box warning that says estrogen may increase the risk for breast cancer. That is no longer true, but the black box warning is still there. And people who wanted to blame hormones said, okay, if estrogen doesn't do it, then it must be progesterone. But in medicine and in science, what you state should be consistent with available data. And we know that women with chronic progesterone deficiency, who therefore should have, if that were true, a lower risk of developing breast cancer, have a 5-fold greater risk of developing breast cancer. When progesterone is compared to tamoxifen in the treatment of metastatic measurable breast cancer, it is more effective. The only reason tamoxifen is used and not progesterone is progesterone was associated with bloating, fluid retention, and nausea, and that's why tamoxifen is used. Taking progesterone-only contraceptives following treated primary breast cancer does not increase the risk of recurrence. None of that is consistent with progesterone causing breast cancer. The Women's Health Initiative, which said that estrogen alone decreases the risk of breast cancer now by 23%, but they still say that the combination of estrogen and progesterone increase the risk of breast cancer. But if you look at women who have no prior hormone exposure before going to the doctor in perimenopause and saying, I want to try hormones, and that's the majority of perimenopausal women, most do not start it at age 63, there was no increased risk of breast cancer among those women, even within the Women's Health Initiative. And so with all of those benefits, why did the United States Preventive Services Task Force say that the risks outweigh the benefit? And by the way, you hear USPSTF, and I thought that was a subdivision of the United States government. No, it's a voluntary organization of physicians and researchers who got together in 1984 and decided to write recommendations. In fairness, these are respected people. I respect the people I know who are part of that group, but they're wrong. What are the risks they talk about? Well, first, yes, there's a risk of gallbladder disease. Women who take hormones have an increased risk, even if they have no prior history of gallbladder disease, of having a gallbladder attack. What is that risk? For every 10,000 women taking hormone replacement therapy for a year, there will be 50 new cases of gallbladder disease. Now, I don't want to minimize gallbladder disease. A gallbladder attack is painful, and I don't wish that on anybody, and it often requires surgery. But 50 per 10,000, and that's against all of the benefits and the life prolongation that we went through. That makes no sense to me. And so if you challenge people who say the risks outweigh the benefits, what they will usually say is venous blood clots. And it's important that you know that a blood clot in a vein, which causes thrombophlebitis, usually in your calf, and it's a painful swollen leg, is not a blood clot in an artery, which cuts off circulation to the heart or the brain. That's different. All they're talking about is an increased risk of clots in the vein. And so you ask, does that really stand against all of the benefits we just spoke about? Well, sometimes, not often, but sometimes the clot can break off in the vein, travel to the lung, and cause what is called a pulmonary embolus, and a pulmonary embolus can be lethal. And that's very serious. And in fact, hormone replacement therapy has a twofold increased risk of venous thrombosis, which can go on to a pulmonary embolus. That's a relative risk, twofold relative risk. And whenever you see a relative risk, I urge you to ask for the absolute numbers underneath that risk. To go from 1 in 1,000 to 2 in 1,000 is a twofold increased risk. So is to go from 100 in 1,000 to 200 in 1,000, but those are different absolute risks. So the baseline risk of a pulmonary embolus in a perimenopausal woman not on hormones is 2 per 10,000 women years. That means 10,000 women taking hormones for a year, 10,000 women per year can have 2 pulmonary emboli on epidemiologic analysis. If a woman takes hormones, that risk is increased to 4 per 10,000 women years, which means 10,000 women taking hormones for a year can have 4 instead of 2 pulmonary emboli. Again, I am not minimizing pulmonary emboli, but let's remember that this is a discussion of balance. And that's why we went over the benefits first. These are the downsides, and these are all the downsides. And do these really weigh against prolonging life for 3.5 years and reducing heart disease by 50% and reducing osteoporotic hip fracture by 50% and preventing cognitive decline? I don't think so. A normal pregnancy increases the risk of pulmonary emboli to 6 per 10,000 women years. Pregnancy is hard enough without this, but I don't know anyone who says, you know, you really shouldn't get pregnant because you can triple your risk of a pulmonary embolus. Most embolic events occur during the first year of hormone replacement therapy administration. So it's not that every year you keep getting an additional 2. The first year is the hardest, and each year it decreases. And the risk, interestingly, is not increased among women who take transdermal estrogen as opposed to oral estrogen. Why do I have this building here? Oh, I remember. That's the Royal Society in London. The Royal Society is probably the most prestigious scientific society in the world. Isaac Newton presented at the Royal Society, Charles Darwin presented, Albert Einstein, Stephen Hawking, Francis Crick, and James Watson, who described the double helix of DNA, they presented. And with great pleasure, I presented as well, on a much smaller level than these luminaries. But what impressed me when I walked through the front door was over the lintel of the front door of the Royal Society, it says nullius in verba, which translated into English means take nobody's word for it. That is certainly true, especially if that comes from the United States Preventive Services Task Force or other people who will give you bombastic advice independent of the data we discussed today. Thank you.
Thank you, Dr. Bluming. My God. And the thing is, you ended your presentation saying take nobody's word for it, but we are here to take your word for it. So what can you, I mean, you've given us so much great evidence, and at Alloy, we certainly believe that, and we don't believe, it's not a matter of belief. We know from scientific evidence that getting more women estrogen and progesterone if they have a uterus, once they're menopausal, greatly improves their quality of life, greatly alleviates their symptoms, and sounds like, does really prevent some of the plagues of old age. So why do you think this study came out last week? Someone asked us in the chat, oh my, why would they do this? So
the first answer to that question, Anne, is I don't know. It is not nefarious. These are respected people who, as far as I'm aware, and I'm reasonably aware of what's going on, have no hidden agenda here. But and we discussed this before the program, medicine has never been kind to women. When women were doing a lot of the medical care in the 19th century, midwives were delivering babies, a lot of medicine dependent on women. We organized the American Medical Association saying, no, thank you, lady, we'll take it from here. The way women have been treated by a largely male establishment is with inadequate consideration. I mean, we spoke about menopausal symptoms that I was not aware of, and I'm a trained medical oncologist. We spoke about how menopause teaching is not part of medical school teaching, and even within OBGYN fellowships, where these people are completing training in the specialty of gynecology, less than a quarter of them teach anything about menopause, and that has to change. I don't know the people in the USPSTF personally, and I haven't spoken to any of them. I would welcome a conversation with them. The fact that their report does not refer to any of the studies I started with, and I didn't put references up there because for this audience, I think it would just make for jumbled slides, but please know that everything I say, I can defend with reputable studies supporting it.
It's just been unbelievable to me since we started this journey at Alloy it's hilarious actually when we present sometimes we have to go speak to investors, and some of the investors are very smart and receptive to this idea. But once in a while, usually it's a younger man, says, well, what do you mean? If it works and women feel better, why aren't the doctors giving it to them? And it's the darndest thing to try to explain. But then we also go into, all of the other historically female medical issues that have not received their due course. It does seem, though, that menopause seems particularly cruelly left out.
As you know, the mantra that physicians are taught in medical school is primum non nocere, which is first do no harm. And that's been drilled into us from the time we enter medical school. And do no harm, obviously, I don't wish to cause venous clots or pulmonary emboli in people. I don't want to induce gallbladder attacks in people. But in 1993, Melody Cobley in Chicago said, we should change that. Instead of first do no harm, how about first understand, then advise? Know the whole picture before you make a snap judgment. And that's so important, and that hasn't been disseminated widely enough.
I want to get to some of the questions in the chat. And I know we've got you for another 20 minutes or so. So we'll try to get as much in as we can here, because I could go on asking my own questions all evening. And those of you who have asked, we are recording this, and lots of people have asked if they can share this with their friends, or some of them are taking screenshots. We have recorded this and we'll be sharing it afterwards. One question we got from the audience is, are there ways to monitor estrogen and progesterone levels as I believe testosterone levels in men? Monitoring estrogen and progesterone, are there ways? And my question would be, is it necessary?
Okay, well, thank you for adding that latter one. First, yes, we can measure serum estrogen levels, usually in the form of estradiol, which is the highest concentrated form of estrogen in a premenopausal woman, or in most women who are taking estrogen replacement. The problem is that doesn't necessarily correlate with estrogen in the body. A great deal of estrogen is in tissues, and trying to monitor blood levels doesn't really give you a tool that is practical. There are many offices that will send blood or hair or saliva for estrogen levels, and I've never seen a study that reports that that's of benefit clinically. When you're giving replacement, there are standard doses that have been established, and if you're giving replacement for symptoms, and we went through a whole panoply of symptoms, just measuring what you're giving against relief of the symptoms is the most effective way of determining the best dose, but 70% or more of women will respond to a standard dose.
Okay, now the questions are coming fast and furious. How soon can one experience relief from menopausal symptoms when taking estrogen? Also, when taking progesterone, does this allow for optimal relief? So how quickly
does this allow for
optimal relief? So let's talk about basically how quickly.
Okay, thank you.
Yeah.
First, estrogen, usually within a week. Within a week, it's incredibly dramatic. And
dramatic, right? Not traumatic.
DRA, thank you very much. Dramatic, yes. And although progesterone can help treat menopausal symptoms, even in the absence of estrogen, and I believe not as effectively as estrogen, every responsible organization I know of discourages using progesterone in women who don't have a uterus. The reason we use progesterone as part of hormone replacement therapy is because estrogen does significantly increase the risk of uterine cancer among women who are taking estrogen alone. And if you take it with progesterone, you nullify that increase. And if you don't need to nullify that increase, although there are some practitioners who use it, I know of no reputable organization that endorses that.
So another person says, is it reasonable to use estrogen only? And the answer is if you don't have a uterus.
Absolutely.
Another question is, can Dr. Bluming address how a breast cancer pre-vivor, so someone who's tested positive for BRCA or something, can Dr. Bluming address how breast cancer pre-vivor and breast cancer survivor talk to their doctor about HRT?
Well, first, you have to, without being offensive, let the doctor know that you don't want to be dismissed. You really want answers. I can provide references to people who want it, showing that hormone replacement therapy does not increase the risk of breast cancer development among, for example, BRCA positive women, even those with a family history of breast cancer. Even after a BRCA positive woman is treated for primary breast cancer, even if the cancer is estrogen receptor positive, studies show that giving hormones do not increase recurrence. And if the woman gets pregnant after breast cancer, even if she's ER positive and BRCA positive, there is no increased risk of recurrence.
So I think that answers this question. My doctor is stuck on these studies and won't prescribe me HRT because of a family history of BRCA2, even though I do not have the gene. Can I take this? Now, I just want to say that this is actually not a doctor's appointment, and Dr. Bluming is not your physician. So these are not actual diagnoses or prescriptions. But theoretically, can someone with a family history of BRCA2 who does not have the gene take HRT?
The family history does not eliminate a person from eligibility for taking it. And even if the patient has the gene, you are not eliminated from taking it. But as you point out, this has to be worked out with your physician, who hopefully will be informed, and you should be informed, so that a reasonable discussion of benefit versus risk, and you reach some mutually acceptable conclusion.
Okay, this is one I'm just absorbing it. It's a paragraph, but I think I have the same question actually. I'm 52. I just read your book. I have been treated for endometriosis for the last 20 years by taking continuous birth control. So this is for those of us who take continuous birth control without getting periods anymore. So I will be stopping this medication soon. Should I start HRT right away? I'm a believer. My mother has been on it for 25 years. Or should I wait for the symptoms? I would like to prevent symptoms before they arrive.
Okay, again, this has to be discussed with your physician, but you can transition from birth control, which generally has higher doses of hormones, to hormone replacement therapy, which is generally a lower dose. Excuse me for just a minute.
Yes, it's getting very dark out there in California.
That's why, yeah.
Oh, very dramatic.
I think that's better.
You're
Yeah, at least now
disappearing
you
into the
can see me.
darkness.
Yes, okay.
So this is, again, I mean, there's just so many questions about the fear of breast cancer, and it's just really shows you how pervasive this study was 20 years ago, and the sort of continual spread of misinformation. So someone else asked, I'm almost ready to say yes to HRT. I hear people saying that if you have a family history of estrogen receptive cancer, you shouldn't take HRT. I believe you've addressed that. Is that true? And how can I be tested for the risk of breast cancer, of estrogen receptive cancer? Can you be tested for that risk?
Well, for estrogen receptor positive, no. For breast cancer, we now, BRCA1 and BRCA2 were the first two genetic markers we had testing for the risk of breast cancer. There are now something like 16 or 17, and a woman can be tested for that. But remember, I said that number one, having that is not an absolute contraindication to taking hormones. And women who take estrogen and develop breast cancer have a better prognosis than women who develop breast cancer not taking it. Now, please remember, this isn't an M&M, and we're not distributing these like candy. This is serious medicine, but it's serious medicine, the benefits of which clearly outweigh the risks. And headlines don't allow you to understand that.
Lots and lots of questions about various risks for breast cancer. Is there sort of a blanket statement, aside from the title of your book, which is how women can take HRT without increasing their risk of breast cancer? Is there anything we can say to assure a lot of these different people who are asking about a family history of cancer, et cetera? What is the sort of most blanket reassuring, obviously, of course, in conversation with one's doctor, but how can we reassure all of these people who are so fearsome?
As you know, Anne, from our discussions, I hesitate to give a blanket statement to an audience that I don't know.
Yes.
We've given the data in this brief presentation, And I will gladly provide additional information. People are welcome to contact me. I will provide them references. They can look at the book. There are other articles that I've published with Carol Tavris. There are other articles that other people have published, which I've also detailed. And even the blanket statement of the book, just so we all understand, that's from the publisher. That's Little Brown, because they thought that's good for the book. I think it's legitimate, but it's not something that I would have put on the book myself.
Okay, absolutely. And I have to say, in past conversations, when I have pressed you, say, come on, can't you just say this for everybody? You have been very careful. So I appreciate your professional nuance. I'm going to keep asking a couple of questions. Someone wants to ask, what's the difference between the pills and the patches?
That's a very good question. And that also should be discussed with your physician. What we know is that the patch, which is absorbed through the skin, has one major benefit, which is that it hasn't been associated with that small but real increased risk of clots in the veins. And if that's the biggest risk, then you can jump over that hurdle very easily. There may be a small benefit to the pill compared to the patch, because the pill, and this is specifically Premarin, and just so we know, I'm not paid by any pharmaceutical company. I don't get money from anywhere. Premarin has 12 different estrogen metabolites in it, one of which is equilin. And equilin, in both laboratory studies and animal studies, seems to be the best for prolonged brain health. And so there might be a small edge there. In addition, the pill may have a small edge in heart protection. These are small and they're not large studies, and I don't particularly prefer one over the other, but the only differences I can tell you now are the decreased risk of that small risk of increased clot formation and perhaps a slight edge in brain and heart protection.
Okay, right to that point, someone else asked, how, with respect to how estrogen is metabolized by the liver, which I think is like when you take a pill, when you orally take a pill, it goes through your liver, whereas a patch doesn't go through your liver. What do you recommend for women who have issues with their livers? Transdermal?
That's not a question that I can give an easy answer to. Yes, the patch is absorbed directly into the bloodstream, and the first pass through the liver, which would happen if you took it as a pill, what happens if you take it as a patch, it goes directly into the bloodstream. It's absorbed from the subcutaneous tissue. If you take it as a pill, it's absorbed by the blood vessels around the stomach and it's passed through the liver. That's called first pass. Now, there are lots of passes. Every time the blood circulates, it goes through the liver. So I don't know that there's a huge difference. And it depends on the extent of liver disease and what kind of liver disease. And that has to be discussed with your specific physician.
Okay, now the questions are going so fast and furious, and I've really, I'm so sorry, we only have 8 more minutes. So I'm going to try and just try to absorb them and see if there are themes that come up. Quite a few people are asking about the rule of if you're less, regardless of your age, if you're less than 10 years from your last period, is it recommended, or, you know?
Well, all right, that's a fair question. And the answer is, if you're within 10 years of your last period, and obviously some people stop periods in their late 30s and some in their mid 50s. If you're within 10 years of your last period, your tissues are generally healthy enough that the benefits far outweigh the risks. This should be discussed with your specific physician, but that is a general statement against which his advice or her advice can be measured.
Oh my goodness, so many questions. Let's see. Is there a reason to check your hormone levels? I think we've addressed this, and why am I told that we need to have all three hormones balanced to be optimal? I think that the third one is testosterone.
I'm sure the third one is testosterone. Science is a very slow-moving process. The reason I went into all of this discussion about estrogen and progesterone is because that is what we know of as hormone replacement therapy generally. We have over 60 years of experience with some forms of estrogen, Premarin being the best example because that was the first commercially available one in this country, and progesterone. 60 years of experience from which we've drawn these lessons. Testosterone is a relative newcomer here. Testosterone is reportedly given to women to improve their sex drive. And in fact, there are testimonials all over saying it really worked. Well, first you have to be aware that the way a woman gets estrogen when she's premenopausal is the testosterone that she makes in her body is metabolized into estrogen by an enzyme called aromatase.
Wow.
So that if you're giving testosterone, you're giving the precursor to estrogen. Wow. And in my clinical experience, an adequate dose of hormones of just estrogen seems to work very, very well. Now, Rebecca Glaser has published several articles and studies that she's done on testosterone, and although there aren't many, they look good. Now, they don't have the longevity that we have for other hormones, but they look okay. I try to stand on the firmest rock I can because this is still a battle that we are having. And I want to be as sure as I can of the points that I make. And testosterone is straying a little from that central point, but it's something that's worth following.
Okay, I think two more specific questions about HRT, and then I want to ask you one last wrap up, and then I think, unfortunately, we'll have to say goodbye, but we'll ask you back again. Someone is asking about your sources and references, and you've said several times that you're happy to provide those. They are listed in your book.
And by the way, they're in the book, but yes, I'm not asking you to go out and buy the book. You can write to me and I'll send you whatever I have.
And if you want, for now, if you would like to reach out to Dr. Bluming, you can just email support@myalloy.com and we can facilitate the communication, unless you have another way, Dr. Bluming.
That's fine.
And also while we're at it, I just want to remind everyone that if you're interested in coming to Alloy after this talk anytime, anyone who's been here can use the coupon SAVE25 now for $25 off your first order. And now someone on my staff is going to say, wait a minute, it's 25%, but I'm pretty sure it's $25 off the first order. If someone wants to correct me, you can text me. Okay, two last questions. Estradiol vaginal cream. How much is absorbed into the bloodstream?
There is some debate about that. Let me say first that almost, because you never speak in absolutes, but almost every study shows that there is absolutely no increased risk associated with transvaginal estrogen administration, even if it's absorbed into the bloodstream, and some of it is, and it depends on the preparation, but that doesn't correlate with increased risk at all. So that
and again,
I have no.
Just we're talking about is really the venous thrombosis, right, and the gallbladder.
Yeah, and there's no increased risk. That's right. And I mentioned this before, but let me say it again. How much is in the blood does not appear to be an important determinant of any of the benefits or risks we've spoken about. But transvaginal estrogen is okay. And for women with genitourinary syndrome that we went over, it's important to know that almost all the other symptoms will eventually get better over a median of 7.5 years. genitourinary syndrome that we spoke about, the dry vagina, the painful sexual intercourse, the increased urinary tract infections, that'll get worse and worse and worse. That doesn't get better.
Okay, in the last 2 minutes, there's someone just snuck in another question that I want to get answered. Can HRT increase the risk of stroke in older women? I know you addressed at the very beginning, but I think this is someone who came.
Okay. The Women's Health Initiative, their first report said that women who were randomized to hormones had an increased risk, and that's either estrogen alone or estrogen and progesterone, have an increased risk of stroke. The increased risk was, I think, 12 per 5,000, 10,000, but it was an increased risk. And the reason for it, we think, is estrogen can cause platelets, which are small corks that circulate in the blood, to form clumps. Now, platelet clumps are good if you have a cut, because the bloodstream takes them to the side of the cut and they act as a dike that prevents the bleeding. But if you already have narrowed arteries, if you're older, and we all have narrowed arteries as we get older, then a small platelet clump can further narrow an already compromised artery. And so in the first year, if a woman who is way past the 10 years that we spoke about, during the first year that she takes hormones, has some increased risk of a stroke from compromise of one of those already narrowed arteries. If you started around the time of menopause, estrogen actually improves the distensibility of your blood vessels and makes that kind of thing less likely, not more likely.
So the key is that within 10 years. All right, this is the one. I love this question. I was asking many different ways, but 3 in a row. Can you stay on HRT forever?
Yes. Look at that. Look at that. A one-word answer. You know, if
right
somebody
on the dot of 8 o'clock.
If somebody is thyroid deficient, I don't recall anybody saying, well, I want you to take this for 3, 5, 10 years. You put on thyroid and you take it for the rest of your life. Well, if you're estrogen deficient, what we know, and we know this about bone, is if you stop taking it, the benefit that you have, your bones are more elastic, they are more resistant to fracture. Once you stop taking it, that improved bone health dramatically declines, so that within 6 years, it's as if you never took it at all. And the only answer to that is keep taking it. And now the North American Menopause Society has said putting a limit on the time during which you can take estrogen is not supported by any scientific study. Clearly, it should be done along with your physician to be sure that there's nothing happening that's worrisome, but the yes answer stands.
There's so many other great questions here. There's so much more we could talk about. I'm so grateful to all of you for coming and listening and asking these smart questions. There's a great one here I'm dying to get into, but it's 8:01 and we've told everyone that they could have their evening back. Here on the East Coast, it's 8 o'clock, and out on the West Coast where Dr. Bluming is, it's 5 o'clock. So I will thank you all for coming again. If you have, there are a couple of questions I didn't voice because they're very specific to individuals. Case or medical histories. If you would like to go to alloy.com, we have an option where you can consult with a doctor before you're prescribed with anything at all. And again, that coupon code is SAVE25 now. But also, we'll have Dr. Bluming back again, and we encourage you all to keep asking these questions and ask your doctors the questions, and tell us how you're doing at Alloy. Support at myalloy.com. And thank you, Dr. Bluming. Thanks for everything. And thanks to you all for coming.
My pleasure.